our life now.
Yeah.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CARN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone, and it's lovely to see you and welcome you once again to CATHIP's Health Hour. So I'm welcoming our regular listeners and thanking you for your dedication each and every Saturday morning, and also welcoming those who are spending time with us for the first time. My name is Dr. Vanessa Appiah, and I'm your host for today. And I'm happy to say it's my first time of hosting in 2024, so really looking forward to it. So first of all, what is CATHIP? So CATHIP is the Caribbean and African Targeted Health Improvement Program, and it's a collaborative, educative, and empowering health literacy program that really reaches people where they are really at a point that they're able to take control of their health and also to support others. And it's a fantastic partnership of a number of organizations. And these include the Caribbean and African Health Network, CARN, the Black Health Initiative, the Royal Assembly Redeemed Christian Church of God, RAFA International Development Agency, Croydon BME Forum, and the Enfield Caribbean Association. And we really work hard to bring you topics of much relevance to really enable you to live the best life you can in health. And it's for you, it's for your partner, your spouse, family members, your network and friends. And you're here to listen, but it's also an opportunity for you to engage as well as it is for you. So feel free to ask any questions in the chat while the speaker is speaking, and I'll put them together at the end. But also at the end, there is an opportunity for you to come online and ask directly. Just to note, and please be aware that we are recording, so you can watch this again at any time and share with your networks. But if you don't want to be seen on screen, then please do turn your cameras off. So without further ado, now on to our fantastic speaker for today, Dr. Serge Osula, who is a consultant cardiologist, and he's really going to help us get clued up about heart disease. So Dr. Osula, over to you, and thank you so much for being here.
Thank you for inviting me.
Let me just get started. Can you see my screen?
I can see your screen. You're not at full screen yet, but perfect. That's great.
Good. I'm a consultant cardiologist at Warrington and Halton NHS Teaching Hospital. And today we are going to try and get clued up about
So just as we are excited to hear Dr. Osula, and we have lost him, I think, with the internet. So just please bear with us. I'm sure Dr. Serge will be on as soon as possible. Technology, which brings us together, but can sometimes be a bit tricky. So do bear with us as we get him on again. And just to say that we really love when you put your name or you put your details of where you are in the chat. It's great to hear and see where everyone is located. And also, it's fantastic to let us know, are you watching alone or are you watching with friends or family? So whilst we're waiting for Dr. Serge to come on, please do get involved and let us know who you are and where you are. That would be fantastic. And we are working in the background to get Dr. Serge on as soon as possible. Whilst we're doing that, just to say, I did put on there that this is really a show for you. And what's really important is that we work behind the scenes, and I can't take much of the credit. There's fantastic people within CATHIP doing this, but to really identify the topics and also the doctors and clinicians and healthcare professionals to support us. We love hearing from you. So if there are topics that you really like, topics that you haven't heard us speak about before, please do share it in the chat or do email us. We'll put the email in the chat because it is for you, and we get lots of great feedback from you already, just letting us know what you enjoyed. But if there's things that you feel that we're missing and need to do, please let us know. We love hearing from you. Whilst we are waiting for, oh, I love it. So we've got people from Manchester, Happy New Year. We've also got someone from Germany wishing us a Happy New Year. So absolutely fantastic. We have a Dr. Osula back on the screen, back on with us. So I'm really excited to say. So I think Dr. Osula, please go ahead and share your slides. That would be fantastic. And welcome back.
Thank you. I don't know what happened. I was kicked out.
I know it's we've reflected on technology as well, but we're glad to have you back, and we can see full screen, so that's fantastic. So over to you.
Well, we're going to discuss again today about the general overlook of heart disease. In the UK today, about 460 people are going to die from heart disease or circulatory disease. Around 130 of them will be younger than 75 years of age. 7.6 million people are living with heart or circulatory disease in the UK. You're going to have about 260 admissions due to heart attacks, and about 13 babies will be born with heart defects. So it is a big problem for UK health and the UK health economy. And it affects both Caucasians and Blacks, with some slight variations. Even though we have less ischemic heart disease than Caucasians, heart disease or cardiovascular disease is still a major part of or cause of mortality amongst Black Africans. This data comes principally from African American, but I think it can be representative, or it is representative of Afro-Caribbeans. Now, you probably ask me, why has he put the picture of a house? You can consider the heart as a house, okay, where the mortar and bricks are your heart muscle or your myocardium, and the house is like a duplex. So you've got two houses next to each other, or two pumps next to each other, the right and the left pump, and they take blood from the body, pump it to the lungs where it gets refreshed or rejuvenated, comes back to the left side of the heart where it is pumped again to be used by the body. Also, the heart has got 4 valves. These valves ensure unidirectional flow, so they ensure that blood does not flow back from one chamber back into the chamber it has come from, or out of the main vessels it is pumping into. The heart, just like a house, has got plumbing. So it has its own coronary arteries that supply blood to the house, to the heart. And this is a representation. You've got the right and left coronary arteries, and that's what nourishes your heart muscle that allows it to work. It also has its own electrical system, and this is a schematic representation of the electrics within the heart. The impulse is generated in a node called the SA node and travels down a specialized conductive pathway called the Purkinje system. First of all, going through a node called the AV node, which kind of regulates impulses coming from the atria down to the ventricle. And this is a slight schematic representation of how the heart's pump comes. So blood comes in from the main body through the veins into the right atrium, goes through a valve called the tricuspid valve into the right ventricle. From there, it's pumped through the pulmonary artery to the lungs, where it gets rejuvenated. It comes back to the right side of the heart, into the left atrium through pulmonary veins, through the mitral valve into the left ventricle before being pumped out into the aorta, which is the main piping system out of the heart. So you can have health problems with any of these parts of the heart. So what happens if you've got problems with your plumbing? Well, that's your coronary arteries, okay? You can have either angina, heart attacks, you can have aneurysms or stroke. If you've got problems with your house, the pumping action itself, you can end up with heart failure, with cardiomyopathies. You can have problems with your valves, and your valves can either narrow or be stenosed or leak, which we call regurgitation, or you can have infections setting on the valves or in the heart called endocarditis. You can have electrical problems, and you can result either in slow or fast heart rates requiring pacemakers or certain interventions. But you can also have an irregular heart rate called atrial fibrillation, which increases significantly your stroke risk. And we'll discuss all these. Normally, problems with electrics present as symptoms called palpitations. Now, what I did not show in the schematic diagram of the heart or the house is that there's also a sac that surrounds the heart. That sac is called the pericardium, and it can at times get inflamed, resulting in pericarditis. You can have fluid in between the layers of the sac, called the pericardial effusion, or it can stiffen and restrict contraction, called constrictive pericarditis. Plumbing, or the main thing that affects the plumbing, is a process called atherosclerosis. Atherosclerosis, or coronary artery disease, is a disease in which you get cholesterol or fat deposits built up within the lining of your arteries, which ends up blocking the vessel or limiting the blood flow to the vessel, down the vessel. And that reduces oxygen supply beyond the narrowing. That results in a symptom called angina. Angina, strictly speaking, by definition, is a pain which is felt as a tightness or discomfort in the chest. Some people feel it also in their jaw, their arms, the back of the teeth. It is typically brought on by exertion and relieved by rest. It is caused by narrowing of the coronary arteries or reduced blood supply to the coronary arteries, because there are other causes of angina which are not due to narrowing of the coronary arteries. Usually it does not cause permanent damage to the heart muscle itself. You know what, when I gave the example of the heart, it's just like in the heart, in a house, if you have problems with your plumbing, that can actually damage the structure of the house itself. It's the same thing here. If you do have problems with your coronary arteries, you can actually damage the muscle or the pumping action of your heart. What's the difference between angina and a heart attack? Well, angina is actually the symptom of pain. A heart attack occurs when it's not just a narrowing that you're getting, but it's actually a blockage of the vessel. It is wrong to think that it is always the most severe narrowed or atherosclerotic plaque that causes a heart attack. Often it is not. Often there are small plaques that are not actually, under normal circumstances, blocking the vessel. But what happens is that due to various circumstances, that plaque fissures. So it opens up, okay? And when it fissures and is exposed to blood flow, the body thinks, oh, there is a problem here. I need to block this, cover this up. So what it does, first of all, is that it blocks the vessel or the fissured plaque, covers it up with platelets. Okay, platelets are part of your blood component. So they stick together over the ruptured plaque. And then on top of that, you get a red blood clot that forms. You get a thrombus that forms. And that's what actually blocks the vessel, not necessarily the atherosclerotic plaque. Okay. The treatment for a heart attack, right, currently in the UK is what we call primary angioplasty. So you are rushed into hospital as quickly as possible, and they pass a balloon over where the narrowing is, open it up, and at times, or most times, end up putting a stent to keep it open. Now, it is also possible to treat it with what we call thrombolysis. So we use drugs that dissolve the clot. Now, in the UK, we would only use that if the time for you to get primary angioplasty was excessive, and we could not get you to a hospital that does it in time for whatever reason it is. But you know, if you live in the remote areas of Scotland, it's probably the first treatment they will give you will be thrombolysis, rather than, you know, if the delay to take you to a hospital is prolonged, they will thrombolyze you on site. And that's a treatment for a heart attack. The heart attack symptoms are similar to angina. Okay, so you get a pain that radiates, to the back, shoulders, jaw. You can also have symptoms of breathlessness. Most people break out in a cold sweat, and they get unexplained fatigue or tiredness. You can have symptoms of lightheadedness or dizziness. You can have palpitations if it affects your rhythm, especially. Now, importantly, what can we do first of all, what are the risk factors, or what increases our risks to getting coronary artery disease, and what can we do to prevent it? So one of the biggest risk factors for narrowing of the coronary arteries is smoking. Another is hypertension or high blood pressure, high cholesterol and triglycerides, but cholesterol much more than triglycerides. A large body mass index, being overweight. Inactivity, very important bit. Okay, so physical activity is protective. Diabetes and pre-diabetes, and what we call the metabolic syndrome. Now, the question is, what is the metabolic syndrome? Well, it is a combination of excess weight in the abdomen, raised triglycerides, hypertension, raised blood sugars, and low levels of a protective cholesterol. So your cholesterol is a complex molecule, and you've got part of that molecule called the high density or HDL cholesterol, which is somewhat protective. This is a study that was done in the UK amongst Afro-Caribbeans, called the SABRE study. And what it showed is that compared to Caucasians, we tend to have a higher blood pressure reading, through the day, over a 24-hour period, than Caucasians. Okay, so hypertension is a bigger problem for us, and what is important is that we respond there's a slight difference in the drugs that we respond to. So we respond to some drugs better than we do others for blood pressure control. So we should not necessarily be given the same drugs as Caucasians are because of this response. The response is, we respond to all drugs, but better to some than others. What the study also found that by the age of 70, 1 in 3 African Caribbeans will have developed diabetes compared to 1 in 6 Europeans. So we are more prone to diabetes as we go older. So we have more diabetes as we go older. We have more hypertension. And that results that we have a much higher rate of stroke than our Caucasians. The reason for the diabetes is thought to be due to the fat that we have around the waist, especially in women, less so in men. This is also seen in South Asians. So we've been talking about risk factors, and we've gone through a list that we can control. What about the risk factors that we cannot control? One is a family history, which is our genetic makeup, our age. So the older we get, the more likely we have coronary artery disease, especially in women, because women lose the protection that they have due to hormones at menopause. And that protection cannot be replaced by giving hormone replacement therapy. It does not make up for the natural menopause that we have. So women who have the ovaries taken at a younger age, for whatever reasons, that also are more likely to develop coronary artery disease earlier if they have premature menopause. And also a history of preeclampsia during pregnancy increases your risk. Other risk factors are obstructive sleep apnea. That is recognized now as being a huge contributor to health problems, especially cardiovascular problems. It drives your diabetes, it drives your hypertension. It can be a cause of sudden cardiac death. Now, obstructive sleep apnea is when you actually stop breathing during sleep for a period of time. It is corrected by sleeping with a mask called a CPAP mask, which sends continuous pressure down your airways so that your airways do not shut, causing the obstruction. Stress and depression, alcohol excess, birth control pills, particularly in women who are 35 or above, and smoking, anemia, and of course an unhealthy diet, which raises your cholesterol. There is a multiplier effect amongst your risk factors. So one single risk factor doubles your risk of coronary artery disease. If you have two risk factors, you quadruple your risk, and tenfold if you have three risk factors. So by just doing simple things like eating right, being physically active, not smoking, and not being overweight, you can lower your risk of heart disease by as much as 82%. So there's a lot that we can do to help ourselves. What tests may your GP want to check? I mean, we've mentioned that your risk factor is blood pressure, so they should be checking your blood pressure. These are things that, if they don't check, you need to make them check. They should check your cholesterol, and your LDL cholesterol, your HDL cholesterol, and your triglyceride cholesterol. This can be improved by healthy eating, by dietary means, or by statins or other lipid-lowering drugs if required. On average, except if you have a very bad diet, dietary control just reduces your cholesterol by at most 15 to 20%, more 15 than 20. Okay. Also, your large body mass index and waist circumferences should be checked, and an ECG performed, and we'll discuss the ECG later on. How about if the problem is with the pump, with the muscle? Okay. What happens when you have pump failure or heart failure? This is an echocardiogram, which is the same scan that women have when they have babies, looking at the heart. And when I describe the house, looking on this side, this is your left ventricle that we saw. This is your right ventricle. And you can see it's pumping. You can see the black area here reduces significantly when it pumps normally. This is your mitral valve. This is your tricuspid valve. These are your atria. And on this side, which is a different way of looking at it, this is your aortic valve, which you can see opens well, your mitral valve. So this is what a normal heart should look like. Okay. It's important to know, people at times when they talk of heart failure, they don't realize that heart failure is a killer. Okay, and your prognosis with heart failure is worse than many cancers. Okay, so in men, it is only things like lung cancer that really, and colorectal cancer with time, that has a worse prognosis than heart failure. And in women, it is really breast cancer. So even colorectal cancer in women has a better prognosis than heart failure on the long term. So the mortality rates of someone who is admitted to hospital with heart failure is about 10% death within the hospitalization. Okay, if you are discharged, there's a 3% chance that you will die within 30 days. And if you do go home, there's a 32% chance of dying within the first year of admission. So it has a high mortality rate, and it is probably not given the respect that it should as a condition. What are the causes? Another word for causes is etiology. Well, we've just finished discussing coronary artery disease and heart attacks, and in the UK, it is a commonest cause of heart failure or pump failure. And this is another echocardiogram. And if you look at, the contraction of your heart muscle here, this is your left ventricle, compared to what was normal, here there's very little contraction. Okay, so that black bit doesn't come together as it had in the previous heart scan. Other causes are hypertension. You can have what we call a cardiomyopathy, which is a heart muscle disease itself, and that can be either with a dilated heart cardiomyopathy, where it becomes enlarged, hypertrophied or obstructive, where the muscle is thickened, or restrictive. I'll show you some examples of those. Sorry, let's go back. Other causes are valvular abnormalities that can cause heart failure, aortic stenosis, mitral regurgitation are the commonest. Arrhythmias, so very rapid heart rates or very slow heart rates can cause your heart to fail. This is an example of a leaking valve. So the ventricle here is dilated, and you have got a leak of the valve. So this blue coming back down is leaking valve or regurgitant mitral valve. And you can see in this case that there is huge thickening of the wall of the heart. This is called left ventricular hypertrophy. And in this particular case, it is due to an infiltrative condition called amyloidosis. And that causes the heart to fail. Not because it is not contracting well, but because actually it is not relaxing well. So it's this heart failure with preserved ejection fraction is the word used for it. This is an example of a leaking tricuspid valve. So this is a valve on the right side of the heart, which has caused the right heart to be severely dilated into a right atrium, which is also severely dilated. This can be due to actual disease of the tricuspid valve itself, or at times high pressures coming from the right side of the heart called pulmonary hypertension, which could be due at times to just lung disease in itself. So other causes of heart failure are drugs such as alcohol, cocaine. You have what we call high output failure. There's people who are very anemic, the heart rate goes very fast and it can fail. Thyrotoxicosis, which is your thyroid gland being overactive, is another cause. Pericarditis, we've discussed that is sac, especially when it is constrictive. And we've got what we call the cardiorenal syndrome, where there's a link between your kidney and your heart. So if your kidney fails, eventually, because of the hormone changes and fluid dynamic changes, your heart itself starts to fail, and the pumping action goes down. How about valvular heart disease? Your valves, you've got 4 valves, the aortic valve, the mitral valve, the tricuspid valve, and the pulmonary valve. Now, the main valve problem that you see is aortic stenosis. In Africans, you have where you still have rheumatic heart disease. We see mitral stenosis, which we hardly see now in the Western world because of the absence of rheumatic heart disease, or the very low prevalence of rheumatic heart disease. So mitral stenosis is where your mitral valve, the valve on the left side, narrows. Aortic stenosis is where the aortic valve narrows. With aortic stenosis, it comes with age. So as you can see on this graph, that all your valve disease increases with age, but more so your aortic valve disease. And this is an example of a restricted aortic valve which hardly opens. So aortic stenosis is caused by hardening of the valve. In some people, they are born with, normally your aortic valve is the only valve, well, your mitral valve is the only valve that has 2 leaflets. The aortic valve has 3 leaflets, but some people are born with an aortic valve that has 2 leaflets. And if that is the case, they are more prone to narrowings of the aortic valve at an earlier age, and that's called a bicuspid aortic valve, and it runs in families. So if someone has it, or if a member of the family has it, the siblings should be screened for it. Now, aortic stenosis, the prognosis is good until you start developing symptoms. And the symptoms that you can get are either angina, passing out, or heart failure. And if you have developed symptoms, there's a quick decline in your survival rate. So if, for example, you have aortic stenosis, severe aortic stenosis with heart failure, your life expectancy is about 2 years. It's about 3 years if you've got you're blacking out or have what we call syncope, and a bit better 5 years if it is just angina you're having. So this is an echocardiogram, and you can see, if you remember when I showed you the aortic valve, you could see it clearly opening. Here all we see is a lump of calcium, and the valve hardly opens. This is a regurgitant mitral valve. Again, it's resulted in heart failure. The left ventricle is dilated, and there's a huge leak of the through the mitral valve. What are the treatment options for aortic stenosis? Well, it is either surgery, and if you are offered surgery to replace the calcified or the narrowed aortic valve, you'll be offered either a mechanical valve, which is the valve here on the left, or a tissue valve, the valve on the right. The mechanical valve has a longer longevity, but the disadvantage is that because they are prone to causing clots, you have to be on lifelong anticoagulation if you have a mechanical valve. Not so if you have a tissue valve. And now we can also offer what we call a TAVI, which is a percutaneous valve implant going through the groin or other accesses. And here you have the valve introduced as a stent across the narrowed valve. It is then expanded to open up the valve. and it is expanded when the heart is stopped, and it is stopped by rapid pacing to prevent the pumping heart displacing the valve. And then you are left with a functioning TAVI prosthetic valve. And you can see when it turns on that the valve now opens properly with no restriction to flow. The advantage of a TAVI, even though the durability of the valve is less than the surgical valve, is that if you need to, you can put another valve within this valve if this valve was to fail, which is what we call a TAVI within a TAVI. Okay, so we've looked at the plumbing, we've looked at the muscle or the house mass, or your concrete, basically, which is the muscle of the heart. And now we're going to look at the electrics. So your heart has got a specialized conduction tissue, which is responsible for initiating cardiac contraction. So the contraction of the heart is driven by an electric current. This current generates in a node in your right atrium called the sinoatrial node. It discharges and sends a current wave through the atria, then gets to another node called an AV node. Now, this AV node, I always explain, it's like UK borders. It is there to limit the rate at which impulses are coming from the top chamber, especially in cases of atrial fibrillation. Okay, and it then rapidly conducts the impulses through to the myocardium or the muscle itself, leading to contraction. Now we can pick this up on an ECG, which are these wiggly lines. You know, when we talked about the investigation that might be done, these on ECGs is a result of underlying electrical activity. And each bit of the ECG tells you something. So you have your first wave that we see here, the little upstroke here. This is called the P wave, and this is due to the contraction of the atria, the chambers at the top. Then you get your QRS T, which is to do with contraction of the ventricle. Okay, and just by looking at your ECG, it gives us an indication as what actually is happening to the heart at the current time, and what has happened in the heart. So if you've had a heart attack, we will see changes on your ECG that will tell us that you've had a heart attack, and can tell us roughly where or which area of the heart muscle has been damaged by the heart attack. Okay. So it is not just useful in determining what the rhythm is. So this is a normal rhythm coming from the sinus node, and it's therefore called a sinus rhythm. Now, as far as the commonest rhythm abnormality that causes us the most concern is something called atrial fibrillation. Okay, it's the most common form of abnormal rhythm, and it's a major cause of stroke. Okay, so more than 1.5 million people in the UK are diagnosed with atrial fibrillation, and if you have atrial fibrillation, you are 5 times more likely to have a stroke. And the reason why you have a stroke, and the other thing is that the rate of the graph here, what it shows is that the prevalence and rate of atrial fibrillation is going to increase significantly in the coming years. And that is partly because we are living longer, and about 15% of the population 80 and above are in atrial fibrillation. And the other thing that if you're in atrial fibrillation and you have a stroke, your degree of disability is higher than if you have another form of ischemic stroke. So if you have a stroke in atrial fibrillation, the cause is that you have sent a little blood clot that has gone to the brain and blocked a vessel. And that is because in atrial fibrillation, rather than your atria contracting regularly, your atria are fibrillating. So they're just doing this. Okay. And when your atria are fibrillating, you get stagnant blood flow. And if you have stagnant blood flow, you are prone to have little clot formation, and these clots can be displaced and go to the brain and cause a stroke. So the treatment for atrial fibrillation, the biggest risk of atrial fibrillation is a stroke, and the treatment is to actually thin your blood down to give you anticoagulation. Now, what are the causes of atrial fibrillation? The causes are things such as obesity, alcohol, large alcohol consumption, smoking, stress, caffeine, and other stimulants, and inactivity. Okay. Other risks are hypertension, heart failure, ischemic heart disease or history of a heart attack, previous surgery. It's very common, especially after cardiac surgery. Sleep apnea, which we discussed before, and diabetes. Things that are not modifiable, as I said, it's common as you get older. People with congenital heart defects are more likely to be in atrial fibrillation. If you've got a family history, you're more likely to have it. And of course, the male sex. So if you're male, more likely. Symptoms that you expect with atrial fibrillation are palpitations. Now, what are palpitations? Palpitation is an awareness of your heart rate. So it doesn't have to go fast or slow, but just an awareness. That's a palpitation. Normally, as you sit down, most people are not aware that the heart is beating. But when you become aware, that's palpitations. You can have fatigue, breathlessness, especially on exertion, or general malaise. In some cases, 19% will have dizziness or a sensation of anxiety. About 12% will have chest pains, especially if the heart rate is going very fast. But it's important to remember that a good percentage, 15 to 30% of patients who have atrial fibrillation are asymptomatic. Okay, so you may be there thinking you're well and you have atrial fibrillation, and the first sign of atrial fibrillation is when you have a stroke. Okay, and it's very easy to diagnose. All you need to do is to put your hand on your pulse and feel your pulse. And if your pulse is regular, you don't have atrial fibrillation. If it's irregular, then get it seen by a GP so that they can test, because if you have atrial fibrillation, you may be a candidate for anticoagulation or thinning of your blood. And the good thing is that now, in the past, we used to use warfarin to thin your blood down, and you required regular blood tests. But now we just give you a tablet that doesn't require regular monitoring. How do we decide whether you need anticoagulation or not? We use a score called the CHA2DS2 score, and that scores several factors. So if your CHA2DS2 score is 0, then you don't require anticoagulation. Definitely, if it is 2 or above, you need anticoagulation. And 1, if the person is young, you may decide, young or female, so a female under the age of 65 with a CHA2DS2 score of 1, you would not anticoagulate. But if older than that, you will consider anticoagulation. And the CHA2DS2 score, what your acronym stands for is C is for congestive heart failure, H is for hypertension, A is for age. So if you are 65 and above, you score 1. If you are 75 and above, you score 2. D is for diabetes. S is for stroke. And if you've had a stroke, you get 2. And VASC is for any vascular disease. Okay. And you also get 1 for sex if you are female. I've put up here the other problems you have with your electrics can be that your heart rate is going too slow and you need a pacemaker. And this is a pacemaker with wires going on the right side of the heart to the right ventricle, and another wire going to the atrium, which is pacing the heart. Now we put pacemakers for other reasons. So when you have heart failure, at times we'll put a pacemaker to resynchronize the pumping of the heart's function. The heart may not necessarily be going particularly slow, but it resynchronizes cardiac function. And the other device we put in the chest is a defibrillator. So depending on what your cardiac condition is, you may be prone to sudden cardiac death. And this may be due to an obvious abnormality, or at times it is due to congenital problems. So we put this device that detects if your heart goes into a rapid rhythm called ventricular fibrillation and gives you a shock to restore normal rhythm. This is a patient. You can see on this side, the pumping action of the heart is poor. It's hardly pumping. And the patient then had what we call a CRT pacemaker. You can just see the leads here on this side to resynchronize the pumping action of the heart. And you can see as a result, the pumping action of the heart has significantly improved. What about the sac? As I said, the heart is surrounded by what we call the pericardium. And this pericardium can at times get inflamed and cause something called pericarditis. Pericarditis presents itself as pain. It's different from an angina kind of pain. It's often a sharp pain, which is worse with inspiration, and it also worse when you lie down and is by sitting forward. It often is self-limiting, can follow viral infections, but in some patients it can become chronic and requires medication. You can have thickening of the sac itself, which results in constrictive pericarditis. This used to be seen quite often in the days where you had tuberculosis affecting the heart. It is not seen that frequently now. It often occurs after a severe bout of pericarditis, or not often. It can occur after a severe bout of pericarditis. The treatment for constrictive pericarditis is surgical. So you open up the heart and you strip the pericardium away, or you open up the chest. So we're getting towards the end now. What may your doctor want to do when you present to your doctor with a cardiac problem? One, he'll want to do an ECG. And we've seen that because that tells him a lot. That tells what the rhythm is, and that can tell you whether there's been a heart attack. It tells you whether your heart is actually ischemic at the time. he might want to do a chest x-ray. I've shown you several echocardiograms. They will do one that tells you how well the heart is pumping and what state the valves are in. He will do some blood tests. There are blood tests called troponin that tell you whether you're having a heart attack, or something called NT-proBNP, which helps you decide whether your heart is failing or not. On your right here, you have a cardiac MRI. The pictures are similar to echo, but clearer. You can also do stress MRIs to tell you whether there's any narrowing of your coronary arteries, and look at the viability of the heart muscle. You can do stress echo, either giving a drug to make the heart go to simulate exercise, or actually put the patient on a treadmill, and that helps you decide whether you've got narrowing of the coronary arteries. You can do a radionuclide stress test, which is another way of looking at the heart. You can have an angiogram. This is an invasive angiogram where we float a catheter, often going from your wrist or from your groin, and engage the coronary artery. So here we've engaged the left coronary artery, and the left coronary artery, where's my arrow, divide into what we call the LAD, the left anterior descending artery, which comes down here, and this is a circumflex branch. And here they're quite normal in this particular study. We now can get similar information from a CT scan or a CT coronary angiogram. It has limitations. If your heart rate is too fast, you need a slow heart rate to get good pictures, or if the patient moves, the quality of the pictures go down. Very rarely nowadays you can get a myocardial biopsy, or we can do what we call a cardiopulmonary exercise test, where you're put on a bike and stressed, and at the same time you have an ECG taken, and we're also monitoring your oxygen consumption. Now, importantly, what can you do to help yourself? Well, you can start today and make changes one step at a time. Smoking cessation is paramount, especially if you're diabetic. Increased physical activity. Okay, so for adults, you need at least 150 minutes of moderate intensity activity or 75 minutes of vigorous activity in bouts of 10 minutes or more during each week. So moderate activity is exercising to a point of being slightly breathless and getting 1 or 2 beads of sweat. And you need probably to do that between 20 to 30 minutes at least 5 times a week. So if you are exercising but not challenging yourself, you may not be as active as you think you are. So you need to push yourself. And the fitter you get, you have to push yourself a bit further. Okay. The harder you push yourself, the less the time you have to exercise for. Okay. Also, don't be sedentary for prolonged periods of time. Healthy eating, so food that is low in saturated fats, trans fats, and cholesterol. Reduce your salt intake. There is good evidence now that the Mediterranean low salt diet is not just good for the heart, but also good for the brain. Okay, reduce or limit alcohol intake. Eat fruits, grains, and vegetables. Choose fish and poultry over red meat, and things like that. We, try and also maintain a healthy weight. Of course, if you're diabetic, pay attention to it. So watch your food and take your medication. Same thing if you are hypertensive. A large cause of poor blood pressure control in a hypertensive patient is poor compliance. So take your medication as prescribed. So, in conclusion, we've just done a whistle tour of heart disease as a whole. I have not touched on the particular managements of the conditions because that would not it's not within the scope of this particular talk, but can be done another day if that's what is required. I've also not spoken particularly on hypertension because hypertension, although it's a cardiovascular disease, the problems with hypertension are not driven principally by the heart itself. It's driven by your sympathetic and parasympathetic nervous system and the state of your vessels. If you have any risk factors, talk to your doctor. Okay. The most changes you can do yourself. Okay, so prevention is better than cure. Go through the list of what we have shown. Exercise, watch your cholesterol, watch what you eat, healthy eating, and of course, smoking is always a no-no as far as heart disease is concerned. I hope you found this useful, and I'll hand you back to the host.
Thank you so much, Dr. Osula. As ever, every time I host, I'm always in awe and so grateful of to all the speakers. But you were fantastic in setting the scene and that analogy of the house, and then taking us through all those conditions, which I'm sure for many on the line, people have heard of, but weren't actually sure what they truly were. And you've explained it so clearly, and also tying it together at the end about what we can do for ourselves and advise our friends and networks. So thank you so much. We have a number of questions that have come through. So if you would indulge us, and those that are on the line, please, thank you so much for all the private messages that have come through. I've put them together with colleagues to get through them as quickly as we can. But also, if there's anyone on the line that wants to put their hand up and ask a question, feel free. But whilst we're going on to that, I'm just going to go on to one of the questions that came through. And it's really, a number of people have brought this, specifically about Black women. And someone asked, just saying they were curious if there are any specific heart health tips, specifically for Black women, but also people were mentioned about the menopause. And you mentioned that some of the protective aspects are lost with the menopause. And is there anything that they can do? So focus on women and also on menopause. If you've got any reflections there, please.
The situation for women is not different from any other woman. And the main thing to women across board get a bad deal when it comes to coronary artery disease. And that is because their symptoms are not classical. Now, most trials done, which were done a while ago, most of the participants were men. And so the classical symptoms of angina are a sensation of tightness in your chest, which is very specific. Women get a lot of atypical chest pains, so that they come to you and they tell you you've got chest pains, and what they describe does not sound like angina. So for a lot of women, they get delayed investigations because they do not present in a typical manner. But that's something that we are beginning to recognize amongst cardiologists, and that's why women cardiac care is almost becoming a subspecialty in itself, so to bring people to, or make people more aware that the presentations might be different. Now, in virtually all studies that you look at, Black people are very often underrepresented. Most of the Black studies we have come from the United States, but often underrepresented. So the same thing applies. Is, we are at a higher risk of the metabolic syndrome. So watch your weight, watch your cholesterol, and physical activity. It's important, and I always tell people, exercise for exercise sake. Okay, because you may feel, okay, I'm doing my 10,000 steps. That's good. Don't knock it. Okay, but a lot of people, if they're not exercising for exercising's sake, they may do the 10,000 steps, but they may take 10 steps and stop. So they're not actually getting the cardiac activity to a desired level. As I said, about a 20 minutes walk with a bit of a sweat and a slight sensation of breathlessness is what you need to do to ensure that you are getting the full benefit of your activity. So exercise, of course, no smoking. It's not particularly a bad thing, and I don't think that African women smoke as much as our Caucasian counterparts. But we do have, especially in the middle age, a weight problem.
Yeah. And just thank you so much, because one of the things that you've just mentioned about the smoking is one of the questions that came up was about vaping. And someone said that they vape with 0% nicotine. Would this affect the heart? And I've noticed quite a number of more people are vaping rather than smoking.
So with vaping, we've jumped from the devil we know to, with smoking, we've gone from the devil we know to vaping, which is the devil we don't know. And not only is it the devil we don't know, the problem with vaping is that each product you buy is different one from the other. So it's very different. You cannot look at all vapors and say they're vaping the same thing, because they're using different products to vape. So to do a trial looking at vaping and its effect will take a very long time to get the right numbers, and they change these products from time to time. So what you're vaping in 5 years' time is different from what you're vaping now. So we don't really know, what we're doing. I just think it's not a natural thing to be inhaling any form of smoke into your lungs. That's not what your lungs were made for.
I really, again, like your analogy. We've gone from the devil we know to the devil we don't know, and I think that's the key thing about vaping, that it's kind of exploded, but we don't fully know. So just making people aware that we don't know, because I think people think that because it's so available that we understand everything that it does, but we don't. So thank you so much for putting that so clearly. And some people have talked about thyroid disease, and first question, is it true that hyper or hypothyroidism can cause high blood pressure, which can lead to heart disease? That's the first one. And I think you mentioned thyrotoxicosis, and someone said they weren't sure what that meant. So if you could explain that.
The easiest is thyrotoxicosis is hyperthyroidism. That's thyrotoxicosis. So it's when your thyroid is overactive, and your thyroid hormone. So if you are underactive, your basal metabolic rate goes down. If it's overactive, it goes up, and that's why some women use thyroxine for weight loss. they take it because it helps with weight loss. So yes, you can have raised blood pressure in both hypo or hyper, uh, but it's unlikely in a good healthcare setting to cause a problem because it is easily reversible,
Right.
either with thyroxine supplements or with radioiodine if it's severe hypothyroidism or
Mm-hmm.
so
Great.
the drugs that control it. And once you've controlled your either hyper or hypothyroidism, your blood pressure should return to normal. So
Great.
it is the thing with blood pressure is that it is a sustained effect. So we all have peaks of quite high blood pressure through the day. As a matter of fact, if you look at some studies, they're a bit old now, that were done amongst pilots. If you looked at the results, I can assure you that when they take off and land, you wouldn't fly when you see what happens to the blood pressure.
Mm. No. I can well imagine. I can well imagine. And I have two very quick questions. And if there is anyone else on, well, I'm mindful of time, but I also know that we've got a lot of people on who have really enjoyed the presentation. But I think this is something that comes up a lot in terms of people advocating for themselves. So someone has said they're 35, they feel well. Can they ask for their GP for a maintenance heart check? Or, you know, when can they go just for a routine check of their heart? Would you be able to comment on that at all, please?
I think you can, in the absence of symptoms on the NHS and with pressures of the NHS, and with the absence of a family history, I think most GPs will recommend that it is not necessary. Okay. I think the first thing you need to do is to make the right changes. You know, I have patients who come to me and say, oh, my father had a heart attack at this thing. Please, can you check me out? And I tell them, well, stop smoking first. you know, what's going to cause you your problem is your smoking, nothing else. And if I check you out, what I'll ask you is stop smoking anyway. So stop smoking. So the best way to help ourselves is to do those things: eat healthily, exercise, no smoking, keep an eye. So your GP, as part of your workout, should be checking your blood pressure. You can go to your GP and have your blood pressure checked. You know, um, it's reasonable to ask your GP to check your cholesterol, because if you do have familial hypercholesterolemia, then even though you may be eating healthily, your cholesterol may be at levels that predispose you to heart disease. So there's simple tests that can be done. An ECG they should be able to do if you request. But again, I think under the current pressures, in the absence of symptoms, they may be reluctant to do it.
Thank you so much. And I think it will be great to end there, because I know that we'll never be able to go through all the questions. And if as ever, we'll put the email in the chat. If there are further questions, then please let us know and we'll put it all together. And Dr. Osula, you said that you didn't talk about treatments, but it could be done for another time. And I'm sure we'll be calling upon you again based on all the feedback we've had. So you said it openly. So well, I'm going to publicly take you up on that. So, but just to say a huge thank you for your time, for putting the presentation together and taking the time to explain it so clearly. And I'm sure that there'll be lots of ongoing positive feedback through the week. So thank you so much. And just thank you to all that have been listening and engaging. And I'm going to hand over to my colleague at Khan, Peace, who will just talk about some of the health and wellbeing initiatives that are taking place this week. So over to you, please. great. The slides are coming up. Thank you so much.
Yeah, thank you, Dr. Vanessa, and massive thanks to Dr. Osula for the informative presentation, and to you, Dr. Vanessa, for hosting very well. So just quickly before we wrap up the session for today, as usual, we'll be meeting on Saturday again next week for another educative and very informative session. So it will be on Saturday, the 27th, same time. And then to register, please email info@can.org.uk. And then there's also, or you visit, there's a link there that my colleague will post in the chat. Secondly, we have our healthy art sessions, and the focus for next week will be addiction to late night snacking. So are you struggling to break the midnight snack habit and reach your health goals? Please join on Tuesday at 6:30 p.m. And then Dr. Hiba and Sylvia Ofobwe will be hosting the session, followed by our physical instructor, Orlando Grant. Up next is a webinar on Black women's perinatal and infant mental health care services in Greater Manchester. So most of us on the call would know that Black women are 4 times more likely to die during pregnancy. So please join us on the 9th of February to learn more about this. There's also an opportunity for those residents in Galton, Homes for Health steering group members. So we're recruiting people resident in Galton from the Caribbean and African community. Are you renting? And are you familiar with issues like damp and mold, energy inefficiency, infestation, and many more? Please join the steering group and make your voices heard. So there's a QR code to register, and then someone from the team will get in touch with you. Also, we have the Black Health Inequalities Summit taking place on the 25th of March, 2024. The theme is From Recognition to Action. And as you can see, our speakers there, and it's going to take place in London from 10 a.m. to 4 p.m. There's the link there to register and also to make inquiries. Also today at 1 p.m., we'll be having another home office drop-in session. So today's focus is new immigration rules and children born in the UK and abroad. So are you looking for a safe space to discuss important issues affecting your residency and immigration? Please join us at 1 p.m. today. And also to just use this opportunity to appreciate our lead partners, Caribbean and African Health Network, the MFID Caribbean Association, the RAFA International Development Agency, the Royal Assembly Redeemed Christian Church of God, and the Croydon BME Forum. Lastly, the Black Health Initiative, BHI. Thank you so much for joining us today, and we hope to see you all next week.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our Health Hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.